Ready to go. Okay, so thanks everybody. Welcome to this afternoon's second roundtable discussion on COVID-19. Before we begin our discussion today, I think it's useful for us to pause and reflect on the fact that we're meeting on custodial land of the oldest living civilization in the world. We acknowledge the traditional owners of country throughout Australia and recognise their continuing connection to land, waters and culture. We pay our respects to their elders, laws, customs and creation spirits, and we recognise these lands have always been places of teaching, research and learning. I extend that respect to Aboriginal and Torres Strait Islander peoples here today and would also recognise those whose ongoing efforts to protect and promote Aboriginal and Torres Strait Islander cultures will leave a lasting legacy for future elders and leaders. Brisbane Diamantina Health Partners acknowledges the important role Aboriginal and Torres Strait Islander people play within our community. So if I could just ask everyone at the outset to try and keep your cameras off and mute yourself as well, and that will save me having to do that in the background. We're really in the lap of the technology gods today, and we hope that this session works really well for you. We've got a combination of content and dynamic information, and so we'll move into the slides now. So the next slide, please, Misha. Okay, so I just wanted to start by saying thank you to everyone for joining the session today. BDHP's role in our community is to support the connections and efforts of individuals, organisations and communities, and to promote better health for Queenslanders. Our partners are health delivery people, researchers and educators, and leaders who combine their strengths in this state-of-the-art facilities to solve major health problems. Our mission is to enable the integration of innovative research with education, training, clinical care, and highest quality healthcare for our local and extended communities. So welcome everybody today, and thank you very much for your time and attending the meeting. So very briefly, I'll hand over in a second to Peter and Misha, who are from Strategic Momentum Group and are going to conduct expert facilitation for us today. I just wanted to start with some principles of what we're here to do. So from a BDHP perspective, in understanding what's going on in the COVID-19 response and how busy our key stakeholders are in healthcare delivery, our clinicians and clinician researchers and the researchers and educators and the universities are extremely busy. So our principle is really to do everything we can to support the COVID-19 response, but we don't want to get in the way of that. And so we're very focused on, I guess, respectful ways of working. And today what we're doing is identifying what we can collectively do to support that response and working to achieve the mission for the organisation. So I'll hand over now to Peter Bureau from Strategic Management Group and Misha Byrne, who are going to facilitate the session today.
Excellent, thank you, David. Well, we of course met last time and used Zoom in the past. For those of you who haven't been in one of these meetings, and I'd imagine there may only be one or two of you, a couple of rules of thumb. One, sometimes the microphone, while it should kick in, it doesn't. So if you're making a point and others are talking over the top of you, just pause, wait for the microphone to kick in, and then you'll get your opportunity to speak. If you're speaking and we can't hear you, we'll also let you know that your microphone hasn't kicked in. When you ask questions, please just start with your name so that we know who we're talking to. And we also have a chat channel and we have 5 or 6 messages here already. David's going to be managing the chat channel, and the reason that's relevant is if you've got questions or thoughts, he'll be theming those or reading some of those, and so we'll be interacting relatively informally at that level. Any questions so far, David, that you'd like to draw our attention to?
I guess the question I've had is, are we going to be managing the chat thread? And you've already answered that. So if you've got comments, please put them through. Peter will describe a bit more about how we put this thing together, but we'll make a note of the chat file and we'll integrate that in with all the other comments. So there's lots of different channels for you to be providing us with commentary and feedback throughout the session.
Fantastic, thank you, David. We also have a group contribution tool, and this is called Polev, and this enables us to collate the information real time, which is done by algorithm. If you could talk to us a little bit about that, Mish.
I can, thanks, Peter. So some of you may have used this before, including in our last roundtable. If you haven't, what I'd invite you to do now is to grab probably your mobile phone is best, or it can be a new browser window on your desktop computer or laptop. And the web address that we'd like you to go to is polev.com/npgroup. So if you're on your phone, you'd go to Safari. If you're on an iPhone or Chrome, whatever you use to look up web pages, and go to polev.com/npgroup. I can see the first few responses coming in. It may ask you for your name. That just means that we can follow up later on in the session if you've made comments that we wanted to chase up. What we'd be interested in for this first of our 2 check-in polls, in a word, how would you describe your primary role or contribution in relation to COVID-19? And so health has come up several times. The reason we've asked for a single word, you'll notice, is this is a word cloud. So it groups things by the word. And so we're interested to see what's the mix of roles that we have in the group. Health coming up as the largest, but we can see that we've got some informaticians and some people with a background in analytics, people whose role is around innovation, some of our executive leaders. And we've also got people who are collaborating in some different spaces. There is some research. Of course, because the size of the word tells you how many times it's been raised. What's interesting there is, not surprisingly, we've all got health in common. But interestingly, there's a broad diversity of different roles and backgrounds that I'm seeing. I don't know about you. A couple more researchers, but really a very broad diversity in the group. Of course, when we go back and look at this after today, we'll be able to see if you've put health, research and innovation, we'll be able to see that full response, even though it doesn't come up here. So that's helpful for us to be able to go back and look and just make sure that we're adjusting to that.
Very good. Thank you. That gives us a good overview of where you're coming from.
No wonder. I'll just move us on to the next poll then. If you've finished putting those responses in, they'll have all been captured. Our next question then, as we move on, what personally do you want to get out of today? So just thinking about, now this doesn't need to be a single word, this can be a phrase or a comment, but just so we get a sense across the 37 of us on the line now, what's the driving motivation for you in attending this roundtable? One of the things you'll notice up on screen, there's a number next to the words. On your phone or wherever you've entered your response, you've actually got the opportunity to vote for some of those. You'll see it says load, and I can see we've already had sort of 9 responses. I've just given a +1 for the big picture. But you've got the opportunity to vote for as many of those as also make sense to you. And we'll get a sense quite quickly across the group of where our focus is.
This also helps our speakers today focus in on what you're looking for and looking to achieve from this session.
So what's interesting emerging already is that the big picture has resonated for a lot of people, but there are at least 1 or maybe 2 people who said, actually, for me personally, that big picture is not as important. Presumably they're interested in some of the detail as well. So that's obviously a line that we need to walk today. But what I'm observing is that collaboration is a strong theme. It looks like it got put in twice. And so that's a big theme, cohesive research partnership and how we can work together. Okay, thank you for that.
Very good. Thank you, Mish. Perhaps if we move across to you, David, for a quick summary response on the last session and how we've moved since then.
Right. Thank you, Peter. Thanks, Misha. So I guess the start of this process for BDHP, as I said at the beginning of the session, we wanted to work out how we could support the COVID-19 response, to work respectfully with our stakeholders, and to identify what the role is that we can play. And what we realised was that there was a really big opportunity to try and connect a lot of the translational research capacity and capability and activities that were going on around Queensland, as the health system was really super focused on how to create ICUs and deal with what could potentially be a really big influx. We felt there was an opportunity for us to do that. So what I did is I reached out to BDHP's infection, inflammation and immunology theme leaders, and I asked them if there was something we could do. So the first roundtable discussion that we held on the 30th of March wasn't advertised broadly. We were really focused in on people working in infectious disease and virologists and around things like biobanking. And we had a couple of presenters speak on some activities. Now, I'm not going to read these in detail, but just to give you an idea of the information that was presented. So Paul Young from the University of Queensland talked about the work that they're doing, literally leading at a global level around vaccine development and what could be done there. The interesting thing that I saw in the chat thread and the communications that went on around that was how we could link together opportunities for different scientists who are working together and some really clever ideas. We had David Patterson from the University of Queensland talk on the local interventions trials for drug candidates that is being run. And David also spoke about an application around behavioural programs to avoid mass health workers' sick leave. And in fact, today we've got Paul Barnett from Asymmetric who's come along today. He's going to talk a bit more about that application. It's very clever. We talked about the tools to aid infection control and public health, and Scott Beatson from the University of Queensland was able to talk to that. Scott had been heavily involved with the Queensland Genomics program as well. And so lots of really amazing innovation in science, being translated into and working with Pathology Queensland and Forensics and Scientific Services. And Janet Davies, who is the Deputy Director of Research at the Metro North Hospital and Health Service, was really kind to come along and present on how we could approach COVID-19 in biobanking as Janet continues to lead the work around a statewide biobanking system. So this is a really brief overview. What I'd encourage you to do is go to BDHP's website. If you just Google BDHP and you go to the COVID-19 section, you'll see presentations on that. What we learned in the session was also really about what people wanted us to start focusing on. And so we put together this website that's got a lot of really important resources. We've got really amazing strategic commentary coming in from Professor Frank Gannon, who is a strategic advisor to BDHP. And whilst Frank is currently in Ireland, Ireland are probably maybe 2 weeks ahead of us. And so he's had some really interesting insights and been doing some great reviews of scientific papers and starting to provide commentary on that in our blog. We've also got the roundtable information recorded. We've started collating primary resources. And of course, what we're doing is we're pushing and connecting to those primary resources rather than trying to collate it all ourselves. So we've attempted to put this site together. We'd really love your feedback, and we'll keep working to support the community as they look at what's going on. There's a little infographic that you can have a look at there, which is coming up on the screen now. So this collected all of what we got from the first workshop, and we'll continue to put this sort of material together to synthesize what we're hearing from the community. So I'll stop talking now, and we'll move on to our presenters for today.
Excellent. Thank you very much, David. Nancy, I'm wondering whether you may be able to start the charge with the ageing theme with CV-19 and the impact on the aged.
Can't hear.
Just wondering with
do we need to?
Your microphone may be not clicking in.
Hi, now can you hear me?
Ah.
Perfect.
Okay, can you see me? No, you just...
No, you can see your slide.
Okay. Sorry, so I'm Nancy Pahana from the School of Psychology at UQ, and I am the aging theme lead in BDHP, and the aging theme... Oh, there we go.
Your slide. Sorry, Nancy. I thought I'd get you to the start of your presentation.
Is looking to really manage older adults in terms of the healthcare system, in terms of everything from specific illnesses such as dementia to broader consumer and community education. And so I've just put together a few slides about COVID-19 and older adults. And so this slide is just the topics I'm going to talk about. I only have 10 minutes, so I can't talk about everything I'd like to, but I want to talk about some specific risks, also some issues with social isolation and anxiety, which happens to be my research area, the issue of ageism, which I think has gone a little bit under the radar, some specific concerns about nursing homes and palliative care settings, and then what some next steps might be. So although older adult, the evidence to date, and this is an evidence base that's evolving, that older adults are no more likely to contract COVID-19 than younger adults, but that those who do are at a greater risk of having compromised health outcomes. And the recent thing that came out today, after I'd already handed in my slides, was an increasing recognition that those who have been on ventilators have an increased risk of delirium, and the delirium really extending for quite a few days, even after the person has gone home. And I would imagine that further data will suggest that there's an age component in that risk of delirium. But anyway, there are a lot of specific health issues for older adults in terms of COVID-19. And I think that there's a lot of information and misinformation out there. And so from a healthcare perspective, I really think that having easy access to simple information to talk with older patients, their families, caregivers, is really vital. And talking to everyone, including people that may have cognitive impairment, is really key. I think that this sort of a health crisis breeds paranoia and anxiety, and I think having direct conversations with people can't be stressed enough. The other thing is that some of the strategies to mitigate the risk of COVID-19, such as self-quarantine and so-called social or physical isolation, come with risks themselves. So there's the risk, obviously, of people getting out of touch with their social network, but also being unable to work, having perhaps a family caregiver is unable to work, having children at home. All of these things can really put people's psychological well-being at risk. And this may be particularly important for older adults. And then I'm actually just in the middle of writing something on elder abuse now. There's heaps of things that in this crisis could be increasing people's risk of elder abuse. And we've heard a lot about domestic violence and some about child abuse, but I think that the increased risk of elder abuse in the current crisis has been underestimated. You can go to the next slide. Now, social isolation and loneliness are a big topic with older adults. Actually, the Australian data, as well as some overseas data, suggest that actually younger people are at greater risk of social isolation, but there's no doubt in the current context with everyone at home that there is a real risk of social isolation among all populations, including older adults. Older adults may have relied more on face-to-face contact and going out and seeing people, and even people who have no family. For example, they may be going to the store or to other settings to get their kind of social contact. And now these avenues have been closed to them. And so I think that's a particular concern. There are also a lot of older adults that live alone. And of course, living alone does not necessarily mean that you're lonely or at any particular risk. But depending on your ability to and access to resources, again, these can cause risks for mental well-being. As somebody who writes grants all the time, I can tell you that nobody believes older adults can use technology, but actually older adults can use lots of technologies. And actually even my mother has been on Zoom, which is unbelievable. But this is a myth. And I think that older adults are actually quite happy to learn how to use technology. And there are a lot of domestic and international websites that people can push on to older adults to get them able to be connected. And obviously an even better solution is to find a younger person in their family or their social network that they can connect with over getting online. And of course, if people aren't coping, if they are isolated, if they are at risk of depression or anxiety, then they need to be referred to a healthcare professional. I think that ageism is the ism among all isms that is most probably unfortunately tolerated in society, and it can have many negative outcomes for older adults. In the current crisis, I've been amazed myself at the increased ageism, you know, people with on social media promulgating hashtags like COVID-19 is the boomer remover and blaming older adults for a whole raft of things, and that this is actually justified that older people are dying at high rates from COVID-19. So, so this is a big problem. And as you can see of some of the points on the slides, that ageism, you know, does tend to go unchallenged for longer. Personally, in Australia, I think that there's been in the healthcare setting anyway, a very balanced discussion about ethics and ageism in terms of healthcare delivery. In terms of nursing homes, this is a huge setting where people are at particular risk because they have multiple morbidities, and unfortunately, because families now are very restricted in their ability to visit loved ones, then their actual treatment, families are often a critical part of treatment, so that's being impacted. So I think that there's some very good and clear guidelines around nursing homes, but I think the impact there is not only on just people's physical health, but what does that mean that family members aren't visiting? What does it mean for people in palliative care that may not have people around them? And of course, some of the best advice for preventing delirium is to have people around when the person's coming around from, say, being on a ventilator, and of course that can't happen at the moment. I'll also note that there are some specific resources for the Aboriginal and Torres Strait Islander community that may have some particular challenges. So my last slide is sort of where do we go from here? I think the overarching message that our group within BDHP and our various initiatives seeks to stress is that older adults vary tremendously in their needs, their risks, their goals, their ability to engage in coping. Actually, sometimes older adults are better at coping with stuff than younger people because they've been around the block. And that has to be kept in mind, that individual variation when you're treating older people. I think that all health professionals have to guard against any kind of stereotyping in the people that they care for in order to give the best possible treatment to all people. And I think that social isolation, it's going to have to be something that is really actively managed to make sure that people do feel that they're connected, especially given the uncertain timeframes. So I thank you very much for this opportunity to talk about older adults, and happy to take questions, and looking forward to chatting.
Thank you, Professor. That was beautifully said. And at this point, we'd like you to put any questions or comments. We won't necessarily have time to address them here and now, but this then enables follow-up afterwards and lets us aggregate any thoughts. So please, any comments or questions or observations or additional piece of insight, if you could put that on the chat channel, that would be terrific. And David, if you're able to just capture or summarize any of those in the chat window, that would be absolutely fantastic.
Will do.
So any comments or thoughts?
Peter, one of the comments that I got to me personally, and then I sort of encouraged that person to share, was how much more contact they're actually having with their family at the moment. So that's been really encouraging. I shared that that's been a similar experience for me. So we've got a question from Jane Davies. Are there specific considerations with consenting elderly people for COVID-19 research, especially if this is being done digitally? Look, that's a really good question. We might actually follow up with that, because there's quite a bit of work that's moving on around the biobanking and consent, and Professor Davies from the Metro North Hospital and Health Service, who presented last week, is working on that. So we'll make sure we get some information on that that's specific to elderly, and get an update on where that project's going, because I know that Professor Davies is very keenly moving that forward. Oh, here we go. And some more resources coming in as well. That's really terrific. So we'll go and chase those resources. And I think that what's going to happen as we move forward, and we'll get to this at the end, is that we're going to start to see some theme areas emerging where people have a particular interest. So we're starting to work out how to categorise resources. And I think following on from the presentations today, we'll start to work out a way on the website to categorise some of these resources so the list doesn't get too long.
Very good. Excellent. Thank you. Thank you for your feedback, everyone. David, did you want to say a couple of words about the social app, just following up on the presentation that was made last week about Paul?
Yeah, look, just to introduce Paul as he gets himself ready and gets his mic on, I followed up with Paul. In fact, David Patterson connected us when we first started thinking about the first presentation. And Paul and I had an opportunity to speak a few weeks ago. And I just thought that the application, the randomised clinical trial that was going on around this, the fact that we've got a really, what is a really perfect storm in terms of research and health delivery and industry coming together was just such a great demonstration of what BDHP can do and what it can be about, and the sort of amazing work going on in our partnership and our community. And so that was really why I thought it'd be great if I could get Paul to speak, and hopefully he's ready to give us a quick overview of the program that he's engaged in and a little bit of insight into this application. There's a nice segue from Nancy's talk here as well.
Excellent. Thank you, David. Over to you, Paul.
Thank you. Do you mind if I share my screen? Would that be okay? Got it.
Yep, totally fine. Please do. David, you might need to make that available to Paul.
Here we go. So I'll just, is that working?
Yep, that's come
Yes.
through. I can see that now. Thanks, Paul.
Go for it, Paul.
Great, great. Thank you. So yeah, I'm Paul Barnett. I'm with Asymmetric Innovation. We're a design tech firm, really. We've partnered with PentaQuest, a behavioural gamification company that has a gamification engine platform, digital platform, and the University of Queensland. So we talked about our links with David Patterson, and so we're together, I guess, we're a group of behavioural scientists, gamification experts, human-centered design experts, and analysts, and various other skills, and infectious disease. And so we've basically come together to try and address some of the issues that Nancy was talking about, particularly in residential aged care. So our concept here that we've been working on now we've just ticked over 3 weeks. So it started as an idea 3 weeks ago, and we've used a lot of our existing infrastructure and tools to pull together an app that is for aged care workers in the facilities. So just really outlining, I don't think we need a lot of introduction to the challenge here, but there was some media overnight, I think, with London School of Economics talking about up to 40% of deaths are occurring in aged care homes. So the critical need for help with aged care workers to be able to minimise the spread is not to be underestimated. And at the same time, our research with the aged care workers that we've been speaking to over the last 3 weeks sort of tells us, and I think Nancy touched on this as well, around the paranoia that they're going to, they're really petrified about taking the disease from home to work or from work to home. They've got a lot of anxiety about whether they're doing the right things or not. Now, they're highly trained in a lot of the competencies around hand washing and all of the practices that they do. But there is also the need to ensure there's consistency around that. And I guess the key thing for us was that we saw an opportunity to help where there was engagement and incentivization to participate in these changing behaviours and cementing behaviours, rather than a stick approach or a monitoring approach, which might be a little less successful. So the science says that if you want to change a habit from, if you want to generate a habit, you need to do becomes a habit. So our app is is central to that, that we've developed. So I'll just move on. So effectively, in terms of gamification is the use of game-like mechanics, like you can earn points and win things, and we're applying this to a work setting. So it's not about just sort of playing Space Invaders or something, themed or that sort of thing, but it is very much about what are the activities that have the most impact on reducing the spread of the disease, that need to be done on a regular basis, and how can we gamify that so that when you're doing activities, you're earning points, and those points can be added up, and you can see on the screen there. So this is 3 weeks of development. So we're pretty proud of where we've got to so far, but we've got a fair way to go. So you can see that heart symbol in the middle of the front page there on the left. That shows you the further that yellow goes around, the further, and then when you close the loop on the heart, that means you've reached the end of that level and you go up onto the next level. But we'll continue. There's no win state. You can't win at fitness, just like you can't win at preparing and constraining this disease. So it's something that we have to keep at and practice. And so we have a concept of a refresh every fortnight or every month, where everything resets back to 0, and then we're off competing again for the next month. So you can see some of the activities on the right-hand side there around, and this is out of our research here, is that principally there's a baseline which comes out of the infectious disease work, which is around just being safe means being hygienic, doing the practices that that we all know that we should be doing, but being able to do them on a highly regular basis and being reminded about what those things are. Some of those things are check your symptoms and make sure that you're well enough, that you're well to go to work. Working sick is a bit of an epidemic in the health system. So changing some behaviours and mindset around that is really important. There's also in aged care workers, we see people are really passionate about caring for others, but they maybe neglect themselves a little bit. So, and that through this combination of, what Nancy was talking about, the paranoia, anxiety, and the stress of dealing with this over a long period of time, it will make it harder for them to perform their jobs and do them well. So we have some activities in there. Again, backed up by behavioural science and the behavioural research through our interviews, that helps people to feel well and be well as part of the program. We also have other categories in there of activities that people can do around being kind to others. So that can be to your peers and your family. Activities that help support the camaraderie and the team aspect of how aged care workers work, and so on. So there's a lot of we're up to about 100 different behaviours so far that are important, and that gives the app the variety that it needs to keep it interesting. And we also have myth versus fact games, and we're working on some other games that people can do. Behavioural science says that if you're just focused on this stuff the whole time, then that can make you stressed. You need some sort of outlet where you can just switch your brain off. So it's not all hard work. Some of it can be fun as well. And the idea is that it's engaging, and that's why people keep coming back to it. So I just wanted to show you really quickly. Here's a couple of pages. One of the pages here on the left is the Teams interface. So it shows you how your team is progressing. And if you click through on your facility or state, it tells you how your team or your facility is ranked amongst the other participants. Through the feedback we've gotten so far is that aged care workers are quite competitive, so they like to try and beat each other. And we've also got that concept in there around giving thanks. So people are able to, they get a limited number of thanks they can give each week. So there's a bit of scarcity around that. So when they thank each other for, hey Mary, you've done a really great job this week. I've seen you cleaning all the surfaces so regularly. That's excellent. Thanks for your work. That little sort of social boost gives social reward as well as that intrinsic reward of doing well at a game. The other thing in here is a news feed. So I don't think the articles on there are terribly representative of this, but the idea is that it's a highly curated list of articles from very reputable sources that helps drive the facts and rather than popular information that we might see on Facebook that isn't very helpful. So lastly, or near to last, why we're doing this is to do the first randomized controlled trial of behavioural gamification in a healthcare setting with aged care workers. And so we're releasing to up to 9,000 users Wednesday next week. So we're on a really good track to be able to do that. We've had a number of facilities very interested in signing up. Goodwin is a chain of aged care facilities based in ACT and surrounds, and they have 500 users that they're getting online. So they were one of the first to come and talk to us about it. Yeah, so I think the key thing here is that, you know, aged care workers are driven by relationships, and we've got to work with that. I think our ability to do that and incentivize the kind of behaviours that we know can reduce the spreads is going to be important to sustain that over a really long period. I think if we can have that impact, we can really have a great impact on reducing that, you know, that 40% that we talked about before. Additionally, you know, if it works in this context, we're really keen to see, we're in discussions actually around rolling it out in hospital context with, you know, we could do that with cleaners, or we could do that with nurses, or we could do that with a range of different folks. But the key thing is here that it requires that really in-depth understanding of what are the pressures and the daily kind of challenges and rhythms and how do they work, and that's the expertise that we bring to this to be able to do that. And ultimately, if we could release a similar experience to the public, I think that'd be really just an amazing thing to be able to do to drive this with engagement, you know, and a fun, engaging experience rather than a stick. So I'll leave it there and hand it back over to the MC. Thank you.
Excellent. Thank you very much, Paul. And in the chat window, if you could now lodge any of your questions or thoughts or comments, that would be most helpful, because that gives us the opportunity to follow up. And just while you're doing that, Nancy, if you could, yes, following up on what you said before.
Yes. So I just wanted to, there was a question raised about gaining consent or capacity to consent. And so I just want to say really clearly that if you're over 65, the assumption should be that you have the capacity to assent unless proven otherwise. Not everyone over 65 does not have the capacity to consent. They don't have dementia, whatever. And even if someone has dementia or cognitive decline, they may very well have the right to consent, or at least assent should be sought. And that's just a broader statement. So whenever there's discussion about consent and age comes up, there has to be the assumption that the person is starting out with consent, that they have that ability. Otherwise, you're denying them the right to be part of research.
Thank you. Nicely said. Very good. David, any broad questions or comments that have come forward from Paul's presentation?
There were a few discussions about technology, how digital and technology is being implemented. There was a really good comment made about regional access and where technology, these sorts of applications, and we can use telemedicine to reach people in our regional parts of Queensland. So all really good comments. But I think from a time point of view, Peter, we could probably get on to move on to Claire's presentation.
Great idea. And I think, Claire, you're ready to rock and roll.
Yeah, hi everyone. Thanks so much for having me, and I just wanted to say how fabulous the previous two talks have been. So thank you for educating me about that. Can you see my screen?
Yes.
Yes, okay.
No, my screen at the moment. We might need to swap over to yours, Clara.
Yeah, if you could swap over to my screen, that would be great.
So you should hopefully be able to share yours now.
Yeah, just sharing now. So that should be able to see that now.
Perfect.
Okay, now I just have to see how I get my slides up and down. Yeah. Okay, so thanks everybody. So I'm Claire Sullivan, a proud BDHP member with two hats, Metro North and also University of Queensland. So I do find it difficult to give a talk like this because I can't pick up if you're all bored. So if you are bored, indicate somehow and I'll try and modify the content a little bit. It's 10 minutes, so I will stick to time. And thank you, David, for inviting me. I guess this slide really shows what I've been doing for the last month. So I work in Metro North Hospital and Healthcare Service, which many of you know. Many of you are from there, I think. So we have really, I guess, started to experience what it's like to work through a pandemic. This shows the total number of cases in Queensland, and I guess you'll all be very happy, as I am, to see that flattening of the curve there. To give you some sense of what we've been doing in Metro North, this heat map shows the percentage of active cases across Queensland. You'll see it's very pale for most of Queensland, and of course the big red hotspot is Metro North. So we have, unfortunately, more experience than anyone else in the state in managing this at the moment, which is an absolute opportunity and privilege, but also has tested the ways of working, the traditional models of care, the way we interact with our consumers and each other, and the technology that underpins the way that we work. So over the last month, we have set up an innovation and research program devoted to digital COVID-19. The general aim of this program is to transform Metro North Healthcare to deal with the pandemic. We are undertaking a participatory action research and quality improvement strategy with this. And we have started many pre-post observational studies, and I'm pleased to say we have already submitted 2 papers for publication, which I'm happy to talk about if time permits. I thought about 10 minutes is not a long time, so I can't really talk through everything that's happening. And when I spoke to David, I could see the interest was in the kind of innovations that are occurring. So I thought I would actually just give you a very high level snapshot of how Australia's largest hospital and healthcare service is changing in response to the pandemic. The first has been working from home, and that is traditionally discouraged in a clinical setting, and we have had to rapidly set that up. I won't go through all the details, but you can imagine the challenges of getting nurses to work from home, doctors to work from home and still see patients, allied health staff to deliver speech therapy via virtual care. Has been a remarkable undertaking. So that just gives you a taste of what we've done. We've put thousands of people, shifted them from working in the hospital and healthcare service to working from home. So that has been an interesting journey. Probably, and listening to some of the talks today, probably one of the most challenging things we've done is to reimagine the traditional outpatients appointment. So I don't need to talk to any of this audience about the benefits of telehealth, but we're actually shifting away from telehealth. And you'll note that I'm very carefully calling this virtual care. Telehealth suggests traditional care delivered via video screen. What we're doing is virtual care, which is not necessarily synchronous traditional care and involves more than the exchange of images. It involves the exchange of information. It involves the exchange of data such as Internet of Things and Internet of Medical Objects. So it is different to telehealth. We're not calling it that. We are calling it virtual care. We estimate that we have shifted nearly, probably somewhere, I think, between 10 to 20% of our outpatient appointments to virtual care over the last 4 weeks. The disruption that causes has been immense. There are good and bad impacts to that, but it has been necessary to do, and the innovation and the resourcefulness of our consumers and our staff has been remarkable. With this shift, we've also been very conscious of the digital divide. So some staff and consumers have devices and are comfortable using them, and some of them are not. So we have had to put a lot of effort into making sure that we don't have a digital haves and haves not, and happy to talk about that, some more of that at the end. You'll notice that we are using a variety of platforms to deliver this care, and that has been a journey as well, learning the ins and outs of how to do that. The privacy implications have been something that we've had to grapple with, and happy to talk everyone through how we do that. But Scott Morrison, I think, really opened the doors for telehealth in some of his words, so that's been an interesting journey as well. This is just a video that shows how we do the logins. Virtual visits has been really important. So I noticed someone posted in the chat about the NHS might allow virtual visits. We've just done it. So we have set up virtual visits now for consumers and their families. We are conducting family meetings virtually. And the feedback we've had so far from our consumers and their families is that while they would prefer to be in the room, given the current circumstances, this is actually not doing too badly, and happy to talk through how we did that as well. But that has been a revolution, given the strict visitor restriction policies that you've probably seen imposed upon Queensland hospitals, where most people actually aren't allowed visitors or one visitor. So this was a critical part of maintaining the social connections between our consumers and their families and friends. And I'm very proud of this work and the way that it's allowed social connections and nurturing to continue despite the pandemic restrictions. Because many of the people that have COVID, unfortunately, don't survive, particularly once they enter an intensive care environment, being able to hold a family meeting is critical for us. And we've had to talk through and pioneer some of the technology and clinical informatics behind doing that. And that's actually working pretty well now. It was challenging for the first few, but to be able to discuss sensitive topics in a way that we have never had to do before over technology has been a real learning curve for us. And we've made some mistakes at the start, but we have it working reasonably well now. So with the seismic shifts I've just briefly touched on, you can imagine the support and need for our staff to learn. And we have been frantically training people. We have 1,500 staff registered so far, and we've trained hundreds more. And we're expecting probably another 1,000 this week. So the scale of the training has been phenomenal. And I'm so proud of the way that the staff are rapidly adopting new ways of working. That's not to say we're not having distress and mistakes, because we are, but it has been an absolute game changer for me to watch the way with which people adopt things quickly and rapidly. I was very pleased to see my colleague with an app before. So this is one that we have developed here in Metro North as well. This is an app that we developed to track people who are entering self-quarantine with public health orders from the airport. We developed it in a week, and it's now being used by whole of government, including QPS and QFES, and is an app that's used across the jurisdictions. So this was a great example of rapid cycle development and then scaling. And that's actually allowed us to have some really useful information and to care for our consumers properly. As a second app that we developed with COVID, places such as the NHS and Italy have been seeing our workforce absences as high as 60%. And I'm not sure if anyone's aware, but it's very actually hard to know who is absent and sick in real time. So you get the phone calls, you might not realise who's sick for half the day or 3/4 of the day if you're running a big organisation, and Metro North has 21,000 staff. So this app in real time allows us to track who's ill, and probably just as importantly, what skills they have. So if we have 6 ventilator competent nurses suddenly missing from ICU, we've got a problem. So this app actually not just tracks your sick leave, but also the skills and how we might replace you. So that's been a kind of cool thing to develop. This app, Son, allows us to automatically text negative test results to consumers. That was something that we were spending hours phoning people. Obviously, we consent people before this is undertaken, but this has hours and hours and hours of clinician time. David touched a little bit, and I'm conscious of time, David. I won't go over my 10 minutes, but this is an example of the data analytics that we're churning out. So this is the ability to understand in real time the burden of coronavirus on the emergency department, on the inpatient space, in the intensive care unit, and on our community facilities. And the informatics behind setting this up so rapidly has been a challenge. And we are now, I'm showing you some descriptive analytics, but we are running through the full gamut of analytics from descriptive to predictive and prescriptive. We have some collaborations going with industry and with our maths and IT partners to start to do some machine learning on this data, so that we're not just reacting to descriptive analytics, but we can start to see a little bit across that horizon. And last but not least, this is our 3D printing. This has been absolutely a learning experience for me. We have made a face shield, and Matilda there is holding one, that has now been approved by the TGA on Thursday. So first health service to have a TGA approved PPE. We can print these on our printers. We can look at good manufacturing practice and have our community print them. And it's the first step for us. This is a relatively simple item, but obviously there's more that we can do over time, and we're learning how to do this. And we can have a really flexible approach to how we support our staff. As many of you know, globally, this has been a real issue, personal protective equipment. And so we're very proud to be able to think about how we might approach that in a smarter and more innovative way, rather than waiting for supply chain. I'm just going to show you this. I did this yesterday. So this is testing our 3D printed shields. This is a mannequin, and what we've done is simulate aerosolization coming out of the mannequin there. It looks like he's smoking a weed, but it's actually not. So it is a little aerosolization mechanism that we set up inside him. We then sit the clinician as though she's about to intubate the dummy. We simulate the aerosolization, and there's her face with the simulated aerosolization of COVID on her face. And I'll stop. And from an IT perspective or digital perspective, I feel like I would be very grateful if we could reinstall 2020, because I think it does have a virus. So, and I'll stop there right on time. Thank you so much, everyone.
Very good. Nicely done. And congratulations to all three of our speakers for keeping to time. Any other comments that you want to make? Now is the time to do that on what Claire has said. Any questions or any other further follow-up that you would like? What we're also interested in, last week we asked what would be most valuable, and you said as a group you would like information. And so this week what we're interested in is the kind of information. What would be your favourite topics of interest? So what did you find most valuable, and what would you like to hear more about? And are there any other speakers or presenters who you think would be appropriate for this? So just as you're jotting down your comments there, I'm just very aware of our time. We've only got a couple of minutes left, but as we have those collated, any interesting comments or thoughts from your perspective, David, that came through during Claire's presentation?
Yeah, just really quite a few people writing to me just saying how amazing the presentations have been today, and Claire, the work that's being done in Metro North is just exceptional, and the collaborative spirit that you're doing that with research and industry is terrific. I think there are a number of ideas we've already got for a meeting in a couple of weeks, not dissimilar to this. The intention is the broader group know what's going on and to continue to connect people together. So I know we're very short of time, but any feedback you've got, if you can't get it today and you want to push it through to us, info@brisbanediamondteam.org.au, and have a look at our website as well.
Well, it's the joys of internet coverage and the virtual world. You never know quite what's going to happen, and it would seem like this may not be happening right at the moment. No doubt 3 or 4 minutes after the close of the session, it will work like a dream. But if you would also like to put any other final comments or thoughts in the chat window.
Going through will be okay.
That's great.
You should talk.
Excellent. Well,
Great.
Over to you, David, to finish off.
Okay. I'll just wait for the presentation to come up. Excellent. Okay, well, that's the end of it. Look, thanks everybody. I really appreciate people making time out of their busy schedules to attend the event today. I really do hope genuinely that you got some value out of hearing just these few small stories about what we know is going on. Our work is really at the moment trying to collect as much of this as we possibly can. We want to be able to make sure that we can connect people together. So if you've got ideas on presentations, if you've got understanding or knowledge of things that are going on, please let us know. We're very keen to continue to develop the database and the resources that are specific to the partnership here and to continue to work with our partners. So I want to thank our invited presenters for sharing your work today. This presentation would have been very, very boring if it was just myself and Peter and Misha talking. So having the content and Nancy and Paul and Claire make time out of their day for us is just outstanding and exceptional. I want to thank all the participants for making time and sharing your thoughts. So please email and visit us on our website. If you just Google BDHP, you'll find brisbanedonatina.com. And if you go to the COVID-19 site, you'll see information there. Have a look at the feature blogs coming in from Professor Gannon. Have a look at this presentation and this video will go up on the website and any other resources that we can do. We've got a primary resource site and some additional information. And that information is as good as what we get fed and what we can find. So please, I encourage you to get in contact with us. I want to especially thank Peter and Misha from Strategic Management Group for expert facilitation and supporting us again. They've been helping us out pro bono on this, so it's really terrific that they've been able to do us, and it really adds to the meeting. And finally, I want to thank the BDHP team and the board for all of their support and the efforts to make this happen. So please take care, everyone. Wash your hands, be kind to each other, and hang in there. Thank you.
Thanks.